Good day, everyone. We are Group 2, and we are going to discuss SAS 10 to 12.
Good day, everyone. Good day, Doc. We are the second group to report, and today we will tackle about SAS 10 to 12. Before we start, I'd like to give a short information about inflammation. Based on visual observation, the ancients characterized inflammation by 5 cardinal signs. Namely, first, redness or rubor. Second, swelling or tumor. Heat or calor, only applicable to the body's extremities. Fourth, pain or dolor. And last, loss of function or functio laesa. The first 4 of these signs were named by Celsus in ancient Rome, and the last was named by Galen. Inflammation is a series of changes that occur in living tissue following injury, unless the injury is severe enough to destroy the tissue immediately. It was historically seen as harmful until the 19th century, when researchers like Mechnikov highlighted its positive role in the body's defense and healing. Inflammation is now considered a key aspect of pathology, as its observed changes indicate injury and disease. In contemporary understanding, it is acknowledged that inflammation is considerably more intricate than what the basic explanation provided earlier might suggest. It constitutes a significant reaction of the immune system to both tissue injury and infection, although not all infections result in inflammation. Furthermore, inflammation encompasses a wide spectrum spanning from acute to chronic forms. Let's move on to the main topic, which is the acute inflammation. To maintain homeostasis, a class switch activity of enzymes from pro-inflammation to pro-resolution controls temporal regulation of acute inflammation. Acute inflammation initiation is locally produced by lipid mediators such as prostaglandins, prostacyclin, leukotrienes, and thromboxane. These mediators regulate major processes and act as autocoids. They are synthesized in a sequence of enzymatic activation when arachidonic acid, or AAA, is released from the cell membrane due to trauma or via cell-to-cell communication. Structurally, most of the lipids of inflammation are eicosanoids, or 20 carbon chains, and act as endogenous precursor for biosynthesis of a chain of several molecules. While in fact, the enzyme phospholipase A2 releases AA from the phospholipid membrane. This release constitutes the rate-determining step in the generation of eicosanoids produced by most phagocytic and immune cells. Arachidonic acid is rapidly converted into various potent lipid mediators with specific functions in a cell-specific manner by cyclooxygenases, or COX, lipoxygenases, or LOs, or epoxygenases to yield prostaglandins, leukotrienes, and endoperoxides. Arachidonic acids metabolize mostly by 2 major enzyme pathways. First, COX. COX-1 is responsible for basal levels of prostaglandin synthesis, and COX-2 catalyzes the conversion of arachidonic acid to lipid mediators during inflammation. Prostaglandins have 10 subclasses, namely D, E, F, G, H, and I are the most important inflammation. Specifically, PGE2 is generated via PGE synthase in leukocytes, whereas PG12 is generated by prostacyclin synthase in endothelial cells, and thromboxanes, or TXA, are generated by a TXA synthase in platelets. Next, LOs, or lipoxygenase. Lipoxygenase catalyzes the formation of hydroxyeicosate tetraenoic acid, or HETE, from arachidonic acid, leading to the formation of leukotrienes, or LTs, and other biologically active compounds. LTs are predominantly produced by inflammatory cells, including polymorphonuclear leukocytes, macrophages, and mast cells. There are three distinct lipoxygenases that are cell-specific, which are 5-LO in myeloid cells, 12-LO in platelets, and 15-LO in epithelial or endothelial cells. Cellular activation by pathogens in immune complexes results in activation of a sequential enzymatic reaction that includes CPLA2 and 5-LO. 5-LO converts released arachidonic acid to the epoxide LTA4, which undergoes transformation by distinct pathways. One to generate LTB4, which is a potent regulator of neutrophil, chemotaxis, and leukocyte adhesion to endothelial cells. The end products of 12 and 15-LO are 12 and 15-HETE, which are further metabolized. Excessive production of inflammatory mediators such as prostaglandins and leukotrienes with exacerbated sensing response to inflammatory triggers is correlated with progression from acute inflammation to chronic inflammation in many diseases. Favorable inflammatory processes are self-limiting, which implies the existence of termination signals that regulate acute inflammation. Endogenous pro-resolution lipids are produced by enzymatic pathways that switch inflammation to resolution. In addition to pro-inflammatory mediators that turn on inflammation, there is also a separate set of lipid mediators that act as endogenous agonists to activate termination of inflammation by stimulating resolution.
Afternoon everyone, I am Kia Luis Camino and I'll be discussing about the acute inflammation and resolution of inflammation. Before anything else, let's identify first what is acute inflammation and resolution of inflammation. Acute inflammation, it is a short-term, inherent, rapid, and stereotyped reaction to tissue injury or infection. So therefore, acute inflammation is rapid in onset. It usually develops in minutes or hours. It has a sharp duration lasting in several hours or few days compared to chronic inflammation. So this is the redness, warmth, swelling, and pain around tissues and joint that occurs in response to an injury. Resolution of inflammation. It is the termination of an inflammatory response. It is governed by a complex set of mediators that regulate the cellular activities necessary to remove inflammatory cells from location of infection or injury and restore tissue function. Pro-inflammation of the cellular function includes chemotaxis. It is the directed migration of a cell in response to chemical stimulus, such as growth factor. Diapedesis. It is the process in which white blood cells come out of the blood vessels into the surrounding area in case of injuries. NF-key, the activation or the activation of NF-key. Cytokine. It is a small and membrane-bound protein-based cell signaling molecules that aid cell-to-cell communication and immune responses and stimulate the movement of cells towards sites of inflammation, infection, and trauma. Production and apoptosis. Apoptosis is the process of programmed cell death. So the mediators of pro-inflammation are TNFA or tumor necrosis factor alpha, IL-1 or interleukin-1, IL-6 or interleukin-6, CCL2, also known as monocyte chemoattractant protein 1 or MCP1, CXCL8 or CXC motif chemokine ligand 8, histamine, prostaglandins, and leukotrienes. The reaction of the tissue or the tissue response of pro-inflammation are vasodilation, which is the widening of the arteries and large blood vessels, swelling, heat, and pain. The picture on the right side is an example of acute inflammation, which you can see there is swelling and redness. So let's proceed to pro-resolution. Pro-resolution of cellular function includes phagocytosis. It is the process by which living cells like phagocytes engulf or ingest particles or infected cells, decrease chemotaxis, NF-kV inhibition, class switch of enzymes, and efferocytosis. It is the effective clearance of apoptotic cells by professional and non-professional phagocytes. The mediators of pro-resolution are TGFB or transforming growth factor beta, IL-1R or interleukin-1 receptor, IL-10 or interleukin-10, CXCR4 or CXC motif chemokine receptor 4, resolvins, lipoxins, protectins, and maresins. The tissue response of pro-resolution are non-fever, analgesic, and return to homeostasis. Kita natin sa picture na ay blue arrow. From there is inflammation to wala na yung inflammation or na-return to homeostasis na. Acute inflammation is self-limited in clinical scenarios of health, resident cells, molecular mediators, and tissue response to injure and return to homeostasis. If acute inflammation is unresolved, chronic inflammation and disease will establish. Fibrosis can occur when inflammatory injury causes substantial tissue destruction. Connective tissue replacement occurs and results into loss of tissue function. Also, tissue healing is effective when class switch from pro-inflammation to pro-resolution is activated. Lastly, pro-resolution signals are activated mostly by resolvins, lipoxins, maresins, and protectins.
Lipoxins are derived from arachidonic acid by the lipoxygenase pathway, but unlike prostaglandins and leukotrienes, the lipoxins suppress inflammation by inhibiting neutrophil chemotaxis and adhesion to endothelium. They are also unusual in that two cell populations are required for the transcellular biosynthesis of these mediators. Neutrophils synthesize precursors of active lipoxins and pass these to platelets where they are converted to mature lipoxins. Moving on, there are three major lipoxygenases involved in lipoxin synthesis from arachidonic acid, namely 5-LOX, 15-LOX, and 12-LOX. Lipoxins are synthesized through the concerted actions of 15-LOX, acting on arachidonic acid in epithelial cells, such as in the airway, followed by 5-LOX in leukocytes or through the actions of 5-LOX in leukocytes followed by 12-LOX action in platelets. Next, there are three pathways involved for the synthesis of lipoxins. The classic pathway involves 5-LOX activity in leukocytes followed by 12-LOX action in platelets. The action of 15-LOX in epithelial cells, such as in the airway, followed by 5-LOX action in leukocytes, is the second major lipoxin synthesis pathway. The action of aspirin on COX-2 in epithelial or endothelial cells results in the production of the 15 epilipoxins, referred as aspirin-triggered lipoxins or ATLs. Based on this diagram, in the first route of lipoxin synthesis, LTA4 is acted upon by 12-LOX and is converted to lipoxins. The second route involves the action of 5-LOX and 15-LOX, which then gets converted to 15-HPETE. Lipoxins are formed from 15-HPETE by the action of either 5-LOX or 12-LOX. The third route is the formation of epilipoxin A4 or aspirin-triggered lipoxin, or ATLs. The no-filled circle represent enzymes, whereas the gray filled circle represent the metabolites or end products.
Hello everyone, I am Hannah Marie de la Cruz, and for today I am going to discuss about resolvins, protectins, and myrisins. Resolvins are endogenous lipid mediators, so some of you might not know what lipid mediators are. They are widely appreciated for their important roles in initiating the leukocyte traffic required in host defense. Resolvins are induced during the resolution phase of inflammation. Resolution phase of inflammation is actually a coordinated and active process aimed at restoration of tissue integrity and function. Resolvins are biosynthesized from essential W3 polyunsaturated fatty acids, EPA and DHA. EPA means eicosapentaenoic acid, while DHA means docosahexaenoic acid. Resolvins induce hallmark functions during resolution of inflammation, including decreasing neutrophil migration, phagocytosis of apoptotic cells, and increasing clearance of infection to activate tissue healing. The two primary groups of resolvin family are E series and D series. E series is obtained from EPA or eicosapentaenoic acid, while D series is derived from DHA, also known as docosahexaenoic acid. In E series, vascular endothelium produces E series resolvins via aspirin-modified COX-2 that converts EPA to 18-rHPEPE and 18-SHPEPE. In D series, DHA-derived D series resolvins have been shown to reduce inflammation by decreasing platelet leukocyte adhesion, and aspirin-triggered DHA conversion produces molecules with dual anti-inflammatory and pro-resolution function. These series resolvins target GPR32 and ALX receptors expressed on platelets and PMN, or polymorphonuclear neutrophils. Protectins. These are biosynthesized via lipoxygenase mediated pathway. The pathway converts DHA into a 17S hydroxyperoxide containing intermediate that is taken up by leukocytes and converted into 1017-DHDHA, known as protectin D1 or neuroprotection. The name accounts for the protective actions observed in neural tissues and within the immune system. So it is so called as protectins because of its protective actions. Human peripheral blood lymphocytes produce protectin D1 with a Th2 phenotype, thereby reducing tumor necrosis factor alpha and interferon gamma secretion, blocking T-cell migration and promoting T-cell apoptosis. Protectins reduce PMN, polymorphonuclear neutrophils transmigration, through endothelial cells and enhance clearance, also known as efferocytosis, of apoptotic PMN by human macrophages. Myrisins. Macrophage mediators in resolving inflammation, myrisins or MAR, have been identified as primordial molecules produced by macrophages with homeostatic functions. MAR1 effectively stimulates efferocytosis of human cells and also has regenerative functions. So when we say regeneration, it is the natural process of replacing or restoring damaged or missing cells, tissues, organs, and even entire body parts to full function in plants and animals.
Let's move on to the next topic. Unresolved chronic inflammation in periodontal disease. This refers to a situation where inflammation, swelling, redness, and irritation in the gums and tissues around the teeth continues for a long time without getting better. This persistent inflammation can harm the health of the gums and structures that hold the teeth in place, potentially leading to more serious dental problems if not properly managed or treated. The oral microbiome modulates oral and systemic immune development, and a physiologic interaction maintains a homeostatic response. Periodontal diseases is a chronic inflammatory diseases initiated by dysbiosis and microbial biofilms.
The clinical implications are as follows. Inflammation is a biologic response to harm. Gingivitis causes acute inflammation that is reversible and self-limiting. Chronic periodontitis is characterized by a failure of signals that trigger resolution and restore homeostasis. Inflammation and resolution are linked to systemic disease, for example, type 2 diabetes, cancer, and cardiovascular disease, and periodontal disorders.
Hello everyone, this is Kizara Durapan and I will be discussing the diagrammatic presentation of stage 1 gingival inflammation of Page and Schroeder. Stage 1 is also known as the initial phase or the subclinical phase. Clinically, this initial response to bacterial plaque is not apparent and therefore referred to as subclinical gingivitis. It is the first manifestation of gingival inflammation. There are vascular changes in this stage consisting of dilated capillaries and an increase in blood flow. If the host response is good, the initial lesion would resolve rapidly, leaving the tissue to the normal state. But if the host does not respond well, then the lesion might take up a chronic form and there might be infiltration of macrophages and lymphoid cells. So to simplify, stage 1 gingivitis is basically just a surface level gingivitis. It's the least traumatic of all the stages. Now let's move on to the histology of stage 1 gingivitis. Histologically, there is an increase in the number of leukocytes. There is an increase in the gingival crevicular fluid flow due to an increased accumulation of leukocytes within the gingival sulcus. Leukocytes increase within the junctional epithelium in the connective tissue. There is a widening of the blood vessels. As you can see here in the picture, there is a seemingly normal appearance of the gingiva, but this is actually stage 1 gingivitis. There is no signs of severe inflammation or enlargement of the gingiva.
Hi everyone, this is Sheena Andres reporting for gingival inflammation stage 2, also known as early lesion stage. So in this stage, it usually starts at 4 to 7 days or 1 week after the beginning of plaque accumulation. So in this stage, it's just somewhat of an exaggeration of everything that happened on stage 1. There will still be more than usual though of vascular permeability causing migration of more inflammatory cells such as neutrophils, macrophages, monocytes, some plasma cells, and mast cells, and mostly composed of 75% of T lymphocytes found at the connective tissue just beneath the junctional epithelium. And also consider that they are inflammatory cells. They are given to have a growth factor leading to angiogenesis and proliferation of capillaries and increase of formation of capillary loop. And also, this inflammation triggers the red peg or red ridges, causing it to clinically appear erythematous. In layman's term, it will appear redness and probably swollen, and bleeding on probing and gingival sulcus becomes deeper. And also in this stage, guys, there's an important or significant event that happened because after 6 to 12 days, lymphocytes will try to attack, or the cells involved will try to attack and destroy the invading bacteria by producing enzymes and free radicals. Though it is fine if it is intercellular level lang, but since it is released extracellularly too, it causes collateral damage to vascular tissues na and some fibers such as lymphinogingival fibers and circular fibers. And so also in the fibroblast, it will show the cytotoxic alteration, which leads to the decrease of collagen production. And so, karang 70% of collagen is destroyed around the cellular infiltrate.
Good day, everyone. This is Lidith Atco Banes, and I will be discussing to you another stage of the gingival inflammation, which is the stage 3, the established gingivitis or lesion, and it is also known as subgingival plaque phase. This is when gingivitis here becomes chronic, and the inflammation here is from moderate to severe. This occurs around 2 to 3 weeks of plaque accumulation or 14 to 21 days after the early lesion. This is characterized by a huge number of infiltrating immune cells within the gingival tissue. The immune cells are the plasma cells, B lymphocytes, and the neutrophils. However, the predominant cells are the plasma cells and the B lymphocytes. B lymphocytes are mainly of immunoglobulin G1 and G3 subclasses. So, there is a presence of localized gingival anoxemia, which is due to engorged and congested blood vessels. Congested means swollen, and impaired venous return and sluggish blood flow or slow moving blood flow. So, the continuous leakage of plasma proteins from the blood vessels causes an increased viscosity of the blood, hence reducing the blood flow in the region. So, reduction in the blood flow causes anoxemia in the region, which gives the marginal gingiva a bluish hue in this established stage. So, the color of the gingiva can deepen due to extravasation of erythrocytes and into the connective tissue and breakdown of hemoglobin into its component pigments. Next, collagenase is an enzyme which is normally present in gingival tissue, and it is produced by PMNs, and which is a type of WBC or white blood cells that includes the neutrophils, eosinophils, basophils, and the mast cells, and also by some bacteria. The activity of this collagenase is increased in inflamed gingival tissue, which causes distraction of the gingival connective tissue. In the chronically inflamed gingiva, there is also increased levels of acid phosphatase, alkaline phosphatase, and many more. Histologically, there is presence of a chronic inflammatory reaction. There is increase in the number of plasma cells and B lymphocytes. Intercellular spaces within the junctional epithelium widens. Intercellular spaces are filled with granular debris along with lysosomes derived from disrupted neutrophils, lymphocytes, and monocytes. Then, tissue components can be destroyed because of acid hydrolysis released by lysosomes. Retiroids can be seen in the junctional epithelium that protrude into the connective tissue, and then collagen fibers are also destroyed within the connective tissue. Around it, they infiltrate disrupted plasma cells, neutrophils, lymphocytes, monocytes, and mast cells.
Hello everyone, I am Maria Isabel P. Figes, and I am going to tackle about the stage 4 of gingival inflammation, by Page and Schroeder, which is the irreversible tissue destruction phase known as periodontitis. As we all know, periodontitis is a severe gum infection that damages the soft tissue and destroys the bone that supports the teeth. If left untreated, it can lead to tooth loss and other serious dental complications. So what is stage 4 of gingival inflammation? This advanced lesion is characterized by the extension of the lesion into the alveolar bone, classified already as periodontitis. This lesion evolves from stage 3 gingivitis. This is characterized by extension of inflammation into the alveolar bone. This is referred to as the phase of periodontal breakdown. Histologically, we can see that there is an extensive inflammation and immunopathologic tissue damage. Also, plasma cells continue to dominate the connective tissue, and PMNS, or the polymorphonuclear leukocytes, dominate the junctional epithelium and crevice. Then your gingiva becomes fibrotic. What do we mean by fibrotic gingiva? Fibrotic gingiva is a hyperkeratinized tissue with an abnormal whitish thickening of the keratin layer of the epithelium. So going back to the picture, it shows the cross-section of stage 4 gingival inflammation, and it is designated by numbers 1 to 9. So for number 1, it is the area where you can see the biofilm that grows laterally and apically along the root surface. The transition from gingivitis to periodontitis is initiated. Number 2, the immune system unsuccessfully continues to try to eliminate the bacteria. The tissue destruction caused by the immune response now overwhelms any tissue repair. For number 3, it is the portion where macrophages produce high concentrations of cytokines, prostaglandin E, and matrix metalloproteinases, or MMPs, that result in destruction of connective tissue and alveolar bone. For number 4, the gingival fibroblasts shift to a state that favors the destruction of the connective tissue and periodontal ligament fibers. For numbers 5 to 6, the polymorphonuclear leukocytes and lymphocytes produce matrix metalloproteinases, causing destruction of connective tissue and periodontal ligament fibers. For number 7, it is the portion where the osteoclasts, stimulated by prostaglandin E, destroy the alveolar bone. For numbers 8 to 9, the junctional epithelium extends root ridges into the connective tissue and migrates apically. So this is the clinical picture of periodontitis. There is attachment loss, destruction of alveolar bone as shown by the lengthening of the tooth crown, and gingival destruction.
Hi everybody, I hope everyone is having a good day. By the way, I am Dan Kenneth Kalanida, and to continue with our report, we are going to be discussing about clinical features of gingivitis. And here are the following. A. Color changes in the gingiva. B. Changes in gingival contour. C. Changes in surface texture of gingiva. D. Changes in consistency of gingiva. E. Changes in position of the gingiva. And lastly, F. Gingival bleeding on probing. So for my part of the report, we are going to be discussing the first clinical feature of gingivitis, which is the color changes in the gingiva. As you can see here on our first slide, we have sample A and sample B showing an image of acute inflammation of the gingiva. So what is an acute inflammation of the gingiva? So it is oftenly described as an increased blood flow to the gingival tissue, causes the tissue to appear bright red, just like we can see on our sample A and sample B. So for our next slide, we have another Example of color changes in the gingiva. This time we have an chronic inflammation of the gingiva. So the chronic inflammation of the gingiva is simply described as the gingival tissue may appear bluish red, just like we can see on our sample B, or purplish red, just like on our sample A, due to stagnation and burst of erythrocytes releasing the hemoglobin content into the area. Now, color changes of gingiva may also be seen in the following systemic conditions. So it is important to notice that there are certain systemic factors which may influence the color of the gingiva. There could be endogenous source of pigments. So endogenous are oral pigments such as melanin, bilirubin, and iron, which can cause oral pigmentation. So melanin pigmentation, just like we can see on our sample A, is a normal physiologic process which is found in highly pigmented ethnic groups. So to continue with our discussions, so we have the following diseases that causes an increase in melanin pigmentation. So the first one we are going to discuss is we have Addison's disease. So as you can see here on our picture, we can see an isolated patches of discoloration which are seen in this disease, which is of varying degree from bluish black to brown, and it is basically caused due to adrenal dysfunction. So to continue, we have the Peutz-Jeghers syndrome. So this disease causes intestinal polyposis and also causes brownish or bluish gray spots on the lips, gums, inner lining of the mouth and skin, just like we see on our sample pictures. So melanin pigmentation is also seen in oral mucosa and the lips. So next we have the Albright syndrome, also known as fibrous dysplasia. So Albright syndrome is a genetic condition that affects your bones, skin, and endocrine system, which causes an café au lait skin pigmentation, just like we can see on our sample picture. Then we have the von Recklinghausen's disease, also known as neurofibromatosis. So just like the other three, this disease also produces areas of melanin pigmentation. In color changes in the gingiva, it is also important to remember that bile pigments can also stain the skin and the mucous membrane. Iron deposition, seen in case of hemochromatosis, also produces a blue-gray pigmentation of the oral mucosa. Disorders related to blood can produce color changes of the oral mucosa, such as anemia, polycythemia, or leukemia. Disorders related to endocrine system and metabolic disturbance can also produce color change, such as diabetes and pregnancy. Exogenous factors which are responsible for color changes in gingiva are as follows: irritants such as coal, metal dust, and coloring agents in food and lozenges. Next is tobacco leads to increase in melanin pigmentation and hyperkeratosis of the gingiva. Lastly, amalgam implantation in the mucosa can lead to localized bluish-black areas of pigmentations. So here are the solution for gingival color changes. First, if a patient wants to get his gingiva depigmented because of aesthetic concern, procedure known as gingival depigmentation can be performed. And there are various ways of gingival depigmentation, such as with the help of scalpels, chemicals, electrocautery, and of course lasers. So that's it for my part of the report, and now we move on to the next slide.
Hi, it's Kazara Durapan again, and I will be discussing the changes in tissue contour. In diseased tissue, the free gingiva is no longer flat, but rolled and thickened as a result of edema at the neck of the tooth. The papillae may be bulbous, blunted, or cratered. Now let's describe each. Bulbous papilla is enlarged and appears to bulge out of the interproximal spaces. Blunted papilla is flat and does not fill the interproximal spaces. Cratered papilla appears to have been scooped out, leaving a concave depression in the mid-proximal area. So, change in the contour of gingiva is mainly seen in cases of gingival enlargement. Normal contour of the marginal gingiva is colloped and knife-edged. In cases of disease, the contour of the gingiva becomes rolled or rounded. Inflammatory changes in the marginal gingiva can lead to formation of clefts. Some may suggest they occur because of traumatic occlusion, and treatment would be occlusal adjustments. As the recession progresses apically, the cleft becomes broader, causing an exposure of the root cementum. So in this picture, we have the Stillman's cleft. It is a mucogingival triangular shaped defect predominantly seen on the buccal surface of a root. The etiology and the pathogenesis of the Stillman's cleft is unclear. However, as mentioned earlier, occlusal trauma due to interferences can be considered. Next, we have the McCall's festoons. These are rolled and thickened band of the gingiva, which is generally seen along the canines when the recession approaches the mucogingival junction. The cause for this enlargement is also unclear, but inflammation and occlusal trauma can be accepted.
Here again, Sheena and Joss to discuss clinical features of gingivitis and changes in surface texture. So for normal surface of gingiva, it usually stippled or shows some stippling. Stippled refers to an orange peel appearance of gingiva, which is caused by numerous small depressions and elevations. So orange peel appearance. So kamantay mo ng panit sa orange mga citrus or lemons, ingana sad ang appearance ato ang normal gingiva. So for the locations of the stippling, it is located at the interdental gingiva and attached gingiva. No need to dig deeper kay na-discuss na ito pag-agi. So for the surface of gingiva can either be smooth and shiny or firm and nodular depending whether the changes are exudative or fibrotic. So ano diagnosis guys, ang ipasabot is dili siya madadali og tawag nga abnormal kung shiny ang appearance sa imuhang gingiva.
Hi everyone, so this is Lidith Etcobanes again, and I am tasked to discuss to you another clinical feature of gingivitis, which is the changes in its consistency. So both the acute and chronic form of gingiva produce changes in the consistency. In chronic gingivitis, both the forms destructive, which is the oedema tubus, and reparative, which is the fibrotic, coexist, and the form which is predominated will define the consistency of the gingiva. So have you been wondering what is the normal consistency of the gingiva? So the normal gingiva exhibits a firm and resilient consistency. Factors that are responsible for this are cellular and fluid content and collagenous nature of the lamina propria. So what happens to the consistency of the gingiva if it has chronic and acute gingivitis? So we can see it here in our table. So please refer to this. In chronic gingivitis, the clinical changes will be soggy puffiness that beats on pressure. So why does this happen? It happens because of the infiltration by fluid and cells of inflammatory exudate. Next, marked softness and friability with ready fragmentation on exploration with probe and pinpoint surface areas of redness and desquamation. So the moment you touch the gingiva here, it starts to bleed na. So it happens because of the degeneration of connective tissue and epithelium associated with injurious substances that provoke inflammation and inflammatory exudate, change in the connective tissue epithelium relationship with inflamed engorged connective tissue expanding to within a few epithelial cells of the surface, thinning of epithelium and degeneration associated with edema and leukocyte invasion, separated by areas in which rete pegs are elongated to connective tissue. Then, firm and leathery consistency. This happens in cases of fibrosis and epithelial proliferation associated with long-standing chronic inflammation. Now, when you talk about acute gingivitis, there will be these clinical changes. First is diffuse puffiness and softening. So this happens when diffuse edema of acute inflammatory origin or fatty infiltration and xanthomatosis. Next is sloughing with grayish flake-like particles of debris adhering to eroded surfaces. So why is this seen? This is seen in necrosis with formation of pseudomembrane composed of bacteria, polymorphonuclear leukocytes, and degenerated epithelial cells and fibrinous meshwork. Then lastly, in vesicle formation. So this is especially seen in cases of desquamative gingivitis. So, ang desquamative gingivitis is a non-specific oral manifestation of systemic disturbances aggravated at times by local factors. So, that is desquamative gingivitis. So, this happens, ang vesicle formation, it happens in cases of desquamative gingivitis, then which later leads to desquamation of the gingiva, and there are receding cases of autoimmune disorders like pemphigus, which are characterized by intercellular and intracellular edema with degeneration of nucleus and cytoplasm and rupture of cell wall here, which is stated in number 3 in underlying microscopic features in acute gingivitis.
Hello, this is Figas again, and I am going to talk about the changes in the position of marginal gingiva. Changes in the position of marginal gingiva. We all know that normal position of gingiva is usually at the cemento-enamel junction or the CEJ. So in cases of inflammation, the gingiva can be above CEJ due to the increase in the size of gingiva. In cases of gingival enlargement, the gingiva will be above CEJ, most of the times covering the clinical crowns as well. Other changes in position of marginal gingiva includes a case of attachment loss. There can be a shift in the position of gingiva apical to the cemento-enamel junction. This is referred to as the gingival recession. Recession is exposure of the root surface by the apical shift in the position of gingiva. There can be two positions of gingiva in recession. First is the actual position, which is the level of the epithelial attachment on the tooth. Second is the apparent position, which is the level of the crest of the gingival margin. It is important to take note that the actual position of the gingiva would determine the severity of the recession and not the apparent position.
To continue with our report, we have the other changes in position of marginal gingiva. So we have the clinical significance of recession here. So the gingival recession can lead to root caries, abrasion or erosion of the cementum, leading to hypersensitivity of dentin. Now we move on to the causes of recessions. So we have the following. faulty tooth brushing techniques, we have tooth malposition, we have friction from soft tissues, gingival inflammation, abnormal frenum attachment, iatrogenic dentistry, trauma from occlusion, and of course, orthodontic treatment.
This is Kazara Durapan again. So, as we all know, our gums bleed when we don't floss regularly. Now let's discuss further about the presence of bleeding in gingivitis. Bleeding on probing is one of the clearest signs of gingival inflammation seen before the gingivitis is even established, other being the increase in the gingival curvicular fluid production rate. Bleeding on probing is a sign of active tissue destruction. Injury can lead to active episodes of gingival inflammation. Injury could be laceration of gingiva during toothbrushing or by sharp pieces of hard food. Spontaneous bleeding is also seen in acute necrotizing ulcerative gingivitis, as the inflamed connective tissue consists of engaged blood vessels. Depending on the severity, duration, and cases, bleeding is considered as more objective visual signs of inflammation. Presence of bleeding is not a definitive indicator of clinical attachment loss, but its absence definitely indicates an excellent negative predictor of future attachment loss. Factors causing gingival bleeding could be local or systemic. Now, what are the local factors causing gingival bleeding? Other than plaque, there are various other contributing factors for gingivitis. They can be anatomic and developmental tooth variations, caries, frenum pull, iatrogenic factors, malposition of teeth, mouth breathing, overhangs, partial dentures, lack of attached gingiva, and lastly, recession. Next, we have chronic and recurrent bleeding. Chronic inflammation is the most common cause of abnormal gingival bleeding. Mechanical trauma can provoke gingival bleeding, either chronic or recurrent. So, mechanical trauma can be from toothbrushing when you brush your teeth too hard, toothpicks, or food impaction when you don't floss your teeth and it gets stuck in between your gingiva, and biting into solid foods like apple. The severity of bleeding and the ease of its provocation depends upon the intensity of inflammation. Once the vessels are ruptured and damaged, mechanism of homeostasis starts, including contraction of the vessel wall, decrease in blood flow. Platelets adhere to the edges of the tissue, forming a fibrous clot which contracts, resulting in approximation of the edges of the injured area. When the area is irritated, bleeding starts again. Lastly, systemic factors causing bleeding. Certain conditions have common feature of a hemostatic mechanism failure, which results in an abnormal bleeding in the skin, internal organ, and other tissues including the oral mucosa. In such condition, the bleeding is spontaneous. Hemorrhagic disorders in which there is abnormal gingival bleeding is seen are as follows: vascular abnormalities like vitamin C deficiency, allergy like Schönlein-Henoch purpura, platelet disorders like thrombocytopenic purpura, hypoprothrombemia like vitamin K deficiency, other coagulation defects such as hemophilia, leukemia, or Christmas disease. Fluctuation in certain hormones such as androgenic hormones have been associated in modifying gingivitis, especially during puberty. Certain medications can also alter the gingivitis like anticonvulsants, antihypertensive, calcium channel blockers, and the immunosuppressant drugs, causing gingival enlargements, which causes gingival bleeding secondarily.
Again, Sheena and Jess to discuss how to carefully describe gingival inflammation according to factors, which are we have three categories or three major factors on how to describe gingival inflammation. We have the duration, the extent of inflammation, and the distribution of inflammation. So for the first one, we have the duration. Under the duration, we have the acute, chronic, and recurrent. So for the acute gingivitis, it is a sudden onset and short duration and can be painful. So kalit-kalit lang ang pag-appear sa gingivitis. So, for the chronic gingivitis, it is slow in onset, painless, and or long duration. So, next would be the recurrent gingivitis, which reappears after having been eliminated by treatment or disappearing spontaneously. So, nibalik ra siya. So for the next factor, we have the extent of inflammation. We have the localized and the generalized gingivitis. So for the localized gingivitis, it confines to the gingiva of a single tooth or group of teeth. And for the generalized gingivitis, it involves the entire mouth. So kung sa localized is particular to that area of the tooth or group of teeth, sa generalized, na-involve na dyan ang whole mouth or ang oral cavity. So, for the third factor, we have the distribution of inflammation. We have the marginal gingivitis, which involves the gingival margin and may include a portion of the contiguous attached gingiva. Next would be the papillary gingivitis, which involves the interdental papilla and often extends into the adjacent portion of the gingival margin. For the third one, we have the diffuse gingivitis, which affects the gingival margin and the attached gingiva and the interdental papilla. So moving on, still me but with different topic, now we will discuss the use of descriptive terminology. First term we have is a localized marginal gingivitis, which confines to one or more areas of the marginal gingiva. So for the next one is we have a localized diffuse gingivitis, which extends from the margin to the mucobuccal fold in a limited area. Another one, we have a localized papillary gingivitis, which is confined to one or more interdental spaces in a limited area. Another term we have is a generalized marginal gingivitis, which involves the gingival margins in relation to all teeth. And the last one we have is generalized diffuse gingivitis, which involves the entire gingiva. The alveolar mucosa and the attached gingiva are affected, so the mucogingival junction is sometimes obliterated. Sabotable naman siya gamay guys, so wala naman ako i-explain, i-dig deeper.
Hello, good morning. I'm Keith Vincent Godinez, and I'm here to talk about gingival enlargement. Now, what is gingival enlargement? According to what I have gathered, gingival enlargement is also known as gingival hyperplasia or hypertrophy. It is an abnormal growth of gingival tissues. If you forgot or do not know what hyperplasia or hypertrophy is, basically hyperplasia is the increase of cell production, while hypertrophy is the enlargement of the cell. Now, on to the classifications. These are the classifications according to etiologic factors and pathologic changes. This is basically what inflammatory enlargement of the gingiva looks like. So, there are two factors of inflammatory enlargement, which is chronic and acute. The first one is chronic. It is the most common of all the gingival enlargements caused by prolonged local irritation of dental plaque or biofilm. Chronic inflammatory enlargement can be localized or generalized. It has slow progress and is painless unless it has acute infection or trauma, which may cause complications. The second one is acute. It is localized, painful, rapidly expanding lesion. This is usually because of bacteria being carried deep into the tissues when things like the bristle of toothbrushes or fragments of the food substances that are forcefully embedded into the gingiva. Now, onto drug-induced enlargement. These are what a drug-induced enlargement looks like. Basing on these pictures, it looks more inflamed than what is normally seen. Occurs on individuals that take phenatin, cyclosporin A, and certain calcium channel blockers. Phenytoin is a medication used in the management and treatment of epilepsy, and cyclosporin is an agent used to treat organ rejection post-transplant. Now, why do these medications cause gingival overgrowth? It's because phenytoin has been shown to induce gingival overgrowth by its interaction with a subpopulation of sensitive fibroblasts, and cyclosporin inhibits the secretion of matrix proteases, contributing to the accumulation of extracellular matrix components in the gingival connective tissue, causing gingival overgrowth. The gingival overgrowth usually occurs within 3 months after taking the medication. The inflammatory response is exaggerated in response in relation to the plaque present. Good plaque control daily will limit the severity of lesions. Drug-induced inflammation has a higher prevalence among children, meaning it is more common to happen to children. This type of inflammation can change gingival contour, size, and color. Gingiva in the anterior sextans is most commonly affected. However, it can occur in posterior sextans. The anterior sextant of each arc includes the incisors and canines, and the two posterior sextants include the premolars and molars. It is also characterized by increased cervical fluid flow and bleeding on probing. There is also no attachment lost. Gingival enlargement is first observed at the interdental papilla. This is the interdental papilla. It is the portion of gingiva between two adjacent teeth. Next is the enlargement associated with systemic disease. This affects the periodontium in two ways. Either it magnifies the inflammation caused by the dental plaque, or it manifests independently of the gingiva, causing gingival enlargement and neoplastic enlargement. Now onto the conditioned enlargements. The first one is pregnancy. The lesion looks like a discrete mushroom like flattened spherical mass that protrude from the interdental papilla or the gingival margin and is attached to a sessile or pedunculated base. It has a dusky red or magenta with smooth, glistening surface that frequently exhibits numerous deep red pinpoint markings. Its consistency is semi-firm but may have a varying degree of softness and friability. The gingival enlargement during puberty has all the clinical features associated with chronic inflammatory gingivitis. It is the degree of enlargement and tendency to develop massive recurrence that distinguishes pubertal gingival enlargement from uncomplicated chronic gingivitis. Vitamin C deficiency. Acute vitamin C deficiency does not cause gingival inflammation. Rather, it causes hemorrhage, collagen degeneration, and edema. Edema of gingival connective tissue. These changes modify the response of the gingiva to plaque.
Plasma cell gingivitis is also referred to as atypical and plasma cell gingivostomatitis and frequently consists of a mild marginal gingival enlargement that extends to attached gingiva. Clinically, gingiva appears as red, friable, and it also bleeds easily. An associated cheilitis and glossitis have been reported. It has also been thought to be allergic in origin, possibly related to the components of chewing gum and dentifrices, which in layman's term is toothpaste. Non-specific condition enlargement. It is a tumor-like gingival enlargement that is considered to be an exaggerated conditioned response to minor trauma. The exact nature of the systemic conditioning factor has not yet been identified. Pyogenic granuloma. The lesion varies from a discrete, spherical tumor-like mass with a pedunculated attachment to a flattened keloid-like enlargement with a broad base. It is bright red or purple and either friable or firm depending on its duration. In the majority of the cases, it presents with surface ulceration and purulent exudation. The lesion tends to involute spontaneously or persists relatively unchanged for years. Treatment for this is surgical excision. So now we're going to move on to systemic diseases causing gingival enlargements. This is the manifestation of systemic diseases independently of the inflammatory status of the gingiva, the systemic disease causing gingival enlargement and neoplastic enlargement. In leukemia, the enlargement may be diffuse or marginal, localized or generalized. It may appear as an oversized extension of the marginal gingiva or a discrete tumor-like interproximal mass. The gingiva appears as bluish red with a shiny surface. The consistency is moderately firm, but there is a tendency towards friability and hemorrhage occurring either spontaneously or on slight provocation. True leukemic enlargement occurs commonly in acute leukemia, but also may be seen in subacute leukemia, and it is seldom in chronic leukemia. Next are the granulomatous diseases. We first have Wegener's granulomatous, which is a rare disease characterized by a granulomatous necrotizing lesion of the respiratory tract, including nasal and oral defects. The initial manifestation may involve the orofacial region and include oral mucosal ulceration, gingival enlargement, abnormal tooth mobility, exfoliation of teeth, and delayed healing response. The etiology is unknown, but the condition is considered as an immunologically mediated tissue injury. The usual outcome of this is death from kidney failure. Then we have sarcoidosis, which is also a granulomatous disease of unknown etiology. It starts in individuals in their 20s and 30s and can involve almost any organ including the gingiva, where red, smooth enlargement can occur. Then we have sarcoidosis, which is also a granulomatous disease of unknown etiology. It starts in individuals in their 20s and 30s and can involve almost any organ including the gingiva, where red, smooth enlargement can occur. Next, we have the neoplastic enlargement, or gingival tumors, which consist of two types, which are benign tumors and malignant tumors. Under benign tumors are fibroma, papilloma, peripheral giant cell granuloma, central giant cell granuloma, leukoplakia, and gingival cyst. Then under malignant tumors are carcinoma and sarcoma. Next is false enlargement. As to what the title indicates, these are not true enlargements of the gingival tissues, but may appear as a result of increase in size of the underlying osseous or dental tissues. According to location and distribution. In localized, the gingival enlargement is limited to one or more group of teeth. In generalized, the entire mouth and the gingiva is enlarged. In marginal, it is only limited to the marginal gingiva. In papillary, it is confined to the interdental papilla. In diffuse, it involves all parts of the gingival marginal, attached, and interdental. And lastly, in discrete, isolated sessile or pedunculated tumor-like enlargement. According to the degree of gingival enlargement. In grade 0, it has no signs of gingival enlargement. In grade 1, enlargement is confined to the interdental papilla. In grade 2, enlargement involves papilla and marginal gingiva. And finally, in grade 3, enlargement covers 3/4 or more of the crown. And that is all for SAS 12. Thank you for watching our presentation. We hope that you learned something from us.